Good morning. I'm so happy that everybody is able to join us today, both in the room and online for our fall meeting of the Napa Council. Our today is centered around clinical care, but we also have updates from other groups, and we're so proud that we put together a very robust agenda for those of you who are here and those who are streaming live. So let me introduce myself. I'm Dr. Adrienne Mims. I'm a family medicine physician and geriatrician. My expertise is quality improvement and health equity, and I serve as the chair of NAPA. What we're going to do first, as you see the agenda, we're going to, after introductions, we'll do federal updates, and then we'll launch into several sessions today and then after lunch around things that are happening in clinical care after diagnosis. After diagnosis. We do a lot with NAPA with trying to ensure that people get diagnosed, and we do a lot with research. But I think that you live your life with dementia until you die. And there's much that happens then that we need to really focus in on. And so that's what we framed today around. So we're going to do introductions, and I'm going to go to my left.
Good morning, everyone. I'm Helen Lamont. I am the designated federal officer for this advisory council, and I work in the Office of the Assistant Secretary for Planning and Evaluation in the Office of Behavioral Health, Disability, and Aging.
Hello, everybody. My name is Tisa Sherry. I'm also with ASPE. I'm the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy. And I'm also currently serving in the acting ASPE role. So wonderful to see you all. Welcome. Thank you for coming.
Good morning, everybody. I'm Jackie Quiroz, a researcher at the Massachusetts General Hospital and the Harvard Medical School.
Richard Hodis, Director of the National Institute on Aging.
Sherry Ling, Deputy Chief Medical Officer, Centers for Medicare and Medicaid Services.
Good morning, Alicia Etheridge, lead of the Alzheimer's Disease Program Team at the Centers for Disease Control and Prevention.
Good morning, my name is Sarah Fontaine. I am the Program Manager for the Alzheimer's Research Program and the Department of Defense.
Hi, I'm Frank Shoemaker. I'm representing the National Institute of Neurological Disorder and Stroke.
Good morning. I'm Latrice Vinson. I'm at the Agency for Healthcare Research and Quality, and I'm the Aging and Implementation Scientist there in the Center for Evidence and Practice Improvement.
Good morning. I'm Bruce Fink with the Indian Health Service, and
Julie Crowder, Indian Health Service.
I'm Deke Cato, CEO of AG Roads. I'm a provider member.
Good morning. I am Joanne Pike. I am the CEO and President of the Alzheimer's Association and the CEO of the Alzheimer's Impact Movement.
Vaughn Cothran, National Alliance for Caregiving.
And we'll go to the phone there. I see Erin.
Good morning. I'm Erin Long. I work for the Administration for Community Living, the Administration on Aging, and run our Alzheimer's and dementia programs.
And I see Helen.
Good morning, everyone. I'm Helen Bundy Metzger, and I am one of two caregiver representatives to the council, and I'm also chair of the Long-Term Services and Support Subcommittee.
And I see Ken.
Good morning. Good to see everyone. This is Ken Kim, and I'm with the Health Center, mainly serving those LEP individuals from immigrant and refugee communities.
And Randy.
Good morning, Randy Bateman, a professor at Washington University in St. Louis and subcommittee chair for research.
And Roberta.
Good morning, all. I'm the other caregiver representative on the council. Good to be here.
Thank you. Have we acknowledged all of the council members? Rhonda?
Good morning, everyone. Rhonda Williams. I'm with Vermont Department of Health, Chronic Disease Prevention Chief, and I'm here representing public health.
Okay, thank you very much. So we're going to go now to our federal updates. Oh, Teresa?
Oh, hi. Yes, so this is Teresa Bracchio, and I'm the director of the Office of Neuroscience at FDA in Cedar.
Thank you. Okay, Helen.
So thank you everyone for joining us today. The first thing I wanted to lead off with, in case you hadn't heard, was that NAPA was reauthorized and signed into law. Yay, October 1st. So we're so thrilled that this work will continue for another decade. We're also thrilled that next year, things won't be up in the air, and are we sunsetting or continuing to move forward? And so many of you have heard through the subcommittees that we are planning for our next decade of work and thinking about how to reframe, refocus for the next decade. And also technology has evolved quite a bit since NAPA was established. So how to create a national plan that is maybe more usable, a little bit less of a burden on the federal employees who stock that document of 180 pages every year, and then review it and read it every year, how to make those things. So look for opportunities over the next year to contribute to that. And we really look to our non-federal members for direction, areas of focus, and sort of what should our shining star be for the next 10 years of NAPA. So that was thrilling. We will also have new federal members joining us from FEMA, FDA, FEMA, SSA, and the third one, DOJ. So we're in the process of identifying those people and inviting them and amending our charter. ASPE will become a real member, which is so exciting because we actually have not officially been a member during this time. And then we will be adding 3 non-federal members. And we will plan to host those with the next cohort of members in the spring, but it'll be earlier in the spring than we normally do, just so we're all on the same cycle. So there'll be some growth to our group, which is very exciting, and some new voices at the table. And we're looking forward to continuing this important work for another decade. Before we do federal updates, I wanted to turn it over to Richard for a quick update.
Thank you, Helen. Well, just want to take a few minutes to acknowledge what many of you may be aware of. That is the recent change in leadership that has surrounded a finding of scientific misconduct. I wanted to assure above all our commitment to working with all of you to maintain trust in the research enterprise by our many communities. I want to announce that Dr. Amy Kelly, who is the Deputy Director of NIA, will now be the Acting Director of the Division of Neuroscience. And most importantly, I want to stress to all of you that the long-standing process and safeguards in place by which we support research are meant to and continue to be sure that we don't have undue influence by any particular person, individual, or even perspective of science. We do what we do best, collaboration with all of you, with the broadest possible input, most transparent process for decision-making, and again, important oversight. This committee, NAPA, is one of those that provides that oversight. So I thank you for your support and your partnership as we continue to maintain the good works of this group, of this committee, and of research in all aspects of Alzheimer's disease and related dementias. Thanks for the opportunity.
Thank you, Richard, for the reassurance. We really appreciate that, and we want to acknowledge Amy Kelly in the room. Thank you for being here.
Okay, with that, we will turn to our federal updates. I'm going to share my screen and then it's going to tell me how to start. There we go, the little presentation thing. The order today is alphabetical, as usual. AHRQ, CDC, FDA, IHS, NIA, and NIN. So with that, I will turn it over to Latrice.
All right. Good morning again, everyone. I'm Latrice Vincent at AHRQ. I'm presenting today on behalf of Dr. Arlene Bierman. She's the Chief Strategy Officer at AHRQ and also our representative on this advisory council. So today I'm going to briefly share 3 updates on 3 different topics with you. Next slide. So the first is ARC's Healthcare Extension Service. So Arlene previously shared this information, but we just wanted to remind you that we've issued 3 notices of funding opportunity or NOFOs to award up to 15 grants for the state-based healthcare extension cooperatives. These are aimed at accelerating the dissemination and integration of patient-centered outcomes research and healthcare delivery to improve health outcomes, especially for those with multiple chronic conditions. This initiative also includes 2 other NOFOs, the National Coordinating Center that's going to provide technical assistance and help guide the cooperative's communication and dissemination efforts. Also, there's a National Evaluation Center that's going to be responsible for assessing program implementation and its impacts across various healthcare settings. The links to the website and the NOFOs are here on the slide. There's also a technical assistance webinar to explain the 3 different components of HES, and those webinars are available on the website as well. Next slide. So while dementia or Alzheimer's disease are not specifically listed in the NOFO, an older adult unfortunately only appears once. The applications focus on older adults with dementia can still be relevant and responsive to this NOFO. So for example, this first bullet here shows or that discusses the interventions that are transformational in nature. This was pulled directly from the NOFO. And we recognize the need for transformational change in healthcare, particularly for individuals living with dementia who often have multiple chronic conditions, whether that's clinical, social, or both. So it's really crucial to be open to new approaches that address the complexity of their needs. So this context here is just really fundamental to those who are working with older adults who may be interested in applying. There's also an opportunity for states to propose or incorporate person-centered care approaches for people living with dementia or people who are at risk for multiple chronic conditions, which again, we know includes people living with dementia. So while the NOFO specifies that each application include a behavioral health or mental health focus, if we take depression, for example, we know that treating depression alone is not enough. And depression often exists alongside other chronic conditions. So it's important to improve the depression care within the context of the whole person. So again, we just want to assure everyone that this NOFO is relevant to the people in the audience here today, and we welcome applications that incorporate dementia and or older adults and their caregivers. Next slide. So the second update I have for you today is on our multiple chronic conditions e-care plan, which facilitates the creation and sharing of a comprehensive e-care plan to enhance care coordination. Arlene has talked about the e-care plan with this group before, so I'm not going to say too much about it here or on the next slide, but we just wanted to provide you with these new links for more information. HL7 has published our e-care plan implementation guide, and we've also published a paper that goes over the methods for the e-care plan. So if you want more details, once the slides are sent out, you can look at them there. Next slide. Also, one other thing, one of the most important things to point out with this development of the e-care plan is the multiple chronic conditions value set library. And this provides interoperable data standards for person-centered care planning. And these value sets are also available to be used actually independent of the e-care plan. And you can also find the links or find the value sets in the link on the previous slide. Next slide. So this slide is a wireframe from the e-care planner that shows how we collect goals. So it allows for setting and tracking of patient, caregiver, and clinician goals. I know the text is small, but I'll walk you through it. So in the first column, a goal may be to walk around the block without pain. And you can see from the third column that this goal was set by a patient. And immediately below that, you see that there's a clinician goal, and that's to eliminate or reduce the need for pain medication. So this helps us to think about how you can start a conversation for shared care planning to accomplish both of these goals. And you can also include caregiver goals as well. I'll also point out, so in columns 5, 6, and 7, we consulted with subject matter experts in goal attainment for this tool. And so we can collect the importance of the goals, so that's column 5, but also readiness for change and how confident someone is in their ability to make the change. And you can also set target dates and prioritize multiple goals. So think like motivational interviewing for the health behavior change folks in the room. And you can also see how this is, it might be relevant to people living with dementia or managing multiple chronic conditions. So for example, developing a goal around improving sleep or increasing mobility or physical activity. So the goals may be slightly different for the patient, the caregiver, and the provider, but it's person-centered and it fosters these collaborative care models. Next slide. And finally, we just wanted to really quickly share a paper that was published last Thursday. So this is hot off the press on person-centered care planning for people living with or at risk for multiple chronic conditions. And as we discussed, we know that most people with dementia have multiple chronic conditions. So again, this is relevant to this group. And there's a link here on the slide, and there's also an invited commentary that goes along with the article. And I'll stop there and happy to address any questions.
All right, good morning. All right, good morning. Again, I'm Alicia Etheridge. I'm the lead of the Alzheimer's disease program team at the CDC within the Healthy Aging branch. And speaking of the Healthy Aging branch, we are very excited, next slide please, to announce a staffing update. Dr. Juan Rodriguez is the new CDC Healthy Aging branch chief. He started with us about a month and a half ago. And so he brings to our program 18 years of experience in CDC's Division of Cancer Prevention and Control, along with many years at the state and local level. He also teaches at Emory University in Atlanta. So we're really glad to have him on board, and we look forward to further integrating him into our NAPA work. Next slide, please. We are also excited to announce a new publication from CDC's Alzheimer's disease program. This is the first study to examine changes in the health of caregivers from pre-pandemic to more recent years using a large population-based sample. So the report is published in the Morbidity and Mortality Weekly Report, or MMWR, and it provides a snapshot of caregivers in the US by looking at the demographic information as well as 19 indicators of health. So this study also compares caregivers to non-caregivers on these indicators and how they've changed among both groups over time. In short, the health of US caregivers continues to be worse than adults without caregiving responsibilities in 13 critical areas of chronic disease, mental health, and health behaviors. So you can uncover more insights from CDC's new caregiver health research by accessing the publication using the QR code on the slide. Next slide, please. So we recently forecasted a new Notice of Funding Opportunity, or NOFO, on grants.gov. This is Public Health Strategies to Address Alzheimer's Disease and Related Dementias. This NOFO is going to continue the work of our National Healthy Brain Initiative and the Bold Public Health Centers of Excellence to address ADRD NOFOs, which both end on September 29th of 2025. So this new NOFO is scheduled to be released on January the 6th of 2025. You can check out the forecast on the grants.gov website using the QR code on this slide. Next slide, please. A really cool feature on grants.gov is you can subscribe to the forecast. So whenever there's an update to the forecast or when the full NOFO is posted, you can receive an email alert. So just click on the red subscribe button in the upper right-hand corner. And I'm very happy to talk in more detail about this NOFO once it's posted in January. Next slide, please. All right, so our Alzheimer's disease program has also funded 5 new projects under CDC's National Partners Cooperative Agreement. I won't go through each of these since we are short on time, but I'm happy to chat later about any of them in more detail. But I do want to highlight that most of these projects were developed in response to the NAPA Advisory Council 2023 recommendations, particularly from the Risk Reduction Subcommittee. Next slide, please. These are the final 2 projects. And next slide. So there is a new free interactive public health learning module called Public Health and Dementia, Part 1, Understanding the Public Health Impact of Dementia. It's now available from the Healthy Brain Initiative at the Alzheimer's Association. So this module was developed in partnership with CDC and Emory Centers for Public Health Training and Technical Assistance. And it provides a baseline introduction to the public health impact of dementia and also shares insight from public health professionals. So for more information on this module or the other suite of training modules that are available, visit the link on the slide. Next slide, please. So we've talked for the past few meetings about the HBI roadmap for American Indian and Alaska Native peoples, which is formerly the HBI roadmap for Indian country. So this document is underway. We are very close to the finish line, excited about it. It is currently in CDC clearance. We're hoping to release it in November. It looks like it may be closer to the first week of December, but we're very excited about this and happy to present on the new roadmap once it is released. Next slide, please. All right, I do want to highlight a very insightful update from Us Against Alzheimer's. This is an organization that we fund under the National Healthy Brain Initiative Cooperative Agreement. So I talked during our last meeting about their digital media campaign, which is an effort that they've undertaken since 2021. This year, they took a very different approach to the campaign. They used the National Alzheimer's Disease Index and Places, which is a CDC surveillance data set, to really focus on identify their focus areas. They identified 6 cities and metropolitan areas to disseminate their ADRD prevention messaging. So they developed 2 culturally tailored messages per priority population, and they focus specifically on African American and Latino populations. And so each of the ads had a learn more. So you could click on the learn more, and it would take you to a Brain Guide website that had culturally tailored information. And so next slide, please. Take a look at this. So you'll notice there was a, if you look at the x-axis, so the number of people reached. So in 2021, 2022, they had a large number of people that they reached. In 2023, the number of people reached went down. That was because they cut their communications budget in half to focus on other efforts within that program. But if you look at the number of clicks from 2021 to 2024, oh my goodness, it dramatically increased. And this is by specifically using data to focus on reaching the populations who they were trying to focus on. So they also changed their strategy to focus not just on who are they reaching, but engagement. So how many people are actually clicking on learn more and going to the website to find out information. So this was very enlightening for me, considering they reached fewer people, but they had 339,000 clicks to that Brain Guide website compared to in previous years, you know, it was 49,000 clicks or less. All right, next slide, please. All right, finally, I'd just like to share we have a new website for our Alzheimer's disease program. This is part of CDC's digital communication modernization and their Clean Slate initiative. So be sure to check it out. It's all the same information we've had before, but it's all user-friendly. So if you have any feedback on that, you know, please feel free to share that with us. Next slide, please. And so my email address is on this last slide. So if you have questions or want to chat, please feel free to reach out. Thank you.
Thank you. Then over to Teresa. Yeah.
Hi, so I just wanted to let everyone know about an upcoming public meeting we're going to be having on December 10th. This is a virtual meeting. So most people may be aware that there is a boxed warning, which is one of our strongest warnings in drug labels for antipsychotic drugs that has been in the label since around 2005. And it's regarding the risk identified of increased mortality in elderly patients. The labeling specifically says with dementia-related psychosis, and it has been class labeling for this class of drugs of antipsychotic drugs. But we are reevaluating the original data that went into that warning, and also considering whether the wording needs to be improved upon, given changes in our understanding of dementias, use of these drugs, and understanding of the terminology as there's new terminology evolving. So this workshop will be a 4-hour workshop where we will initially present some of the initial analyses that led to the boxed warning. We'll have public comment option for stakeholder comments, and then discussion of future steps that we can do to further evaluation of the signal. And this will also fulfill a congressional mandate to do these reanalyses and hold a workshop, which was in the appropriations bill earlier this year. So we're looking forward to having this meeting, and hope to see a lot of people online for this meeting.
Thank you, Teresa. Julie and Bruce.
Morning. This represents something of a transition for Indian Health Service on this council. I'll be stepping away, and Dr. Jolie Crowder will be taking lead. And so she is going to do the update for us today. Jolie, to you.
Thanks. You can go to the next slide. I think Bruce has shared this slide almost every presentation, I feel like, since I've been here, which is good, because I think this slide is this is how we live our work. These are the 4 priorities identified in the 2021 tribal consultation and urban confer, and they drive the work that we're doing every day. We have principally, and I think as you've heard before, the size of the circles are somewhat relative to where we're putting our money and energies. And the largest of those are grants and program awards to tribal communities, Indian Health Service centers, and our urban Indian organizations, as well as some other activities. For instance, this year we're creating a new partnership with the Office of Quality within IHS, and they do innovation awards every year. And so we're providing some funding to and through them to reach other folks that we might not otherwise. The second big bucket of activities are workforce development, education, and training. And thankfully, we've made some really big strides that I have some slides coming up on that. And then tucked up under that is caregiver support and coaching. And we've also started to walk our journey, I think, down that path more substantially this year. And then the third big activity is outreach and dementia awareness. And principally, our work in this space is to and through our healthcare workforce. So IHS employs about 15,000 employees. And we know we don't have counts for the tribal and urban facilities, but imagine it's probably twice that or larger. So a large number of folks to help us get out into communities. And then finally, program support and data. And that's really our staff, our team. We are also working on, and we've finally made some progress on a data dashboard, really an internal document that's going to be used to guide our work, like what we're doing next. So really not, data for the sake of data, but data to drive innovation and change in the system. Next slide. So like the next few slides, our updates are actually graphics and social media images and headlines from the last 3 months. As I mentioned, we have put a lot of emphasis on building our communications infrastructure, and that's social media. So I'm sure people are getting a little tired of seeing our social media messages 3 or 4 and sometimes 5 times a month. But of finding like their reach has expanded significantly, and we're touching a lot of folks that we hadn't before. So this first headline, we were actually really excited. HHS picked it up and pushed out our press release in September. We were able to award 8 new grants, cooperative agreements this year. So that brings our total at this moment to 14. You can see our lovely little map of where they're scattered across the country. And this year's NOFA was a little bit different in that our emphasis was on expansion and sustainability. So these folks get 3 more years. We have 4 that are continued, but we have, they get 3 more years to really work on not just kind of setting up infrastructure, but I think really trying to enhance and improve models of care. And part of that too is billing, like trying to figure that out. How do we sustain their services? Because our grants aren't intended to be sort of lifelong grants. Next slide. These are some highlights of our social media graphics about training and workforce development. We were really excited when I came to IHS in 22, at the end of 22, I started working on the request for proposals for a training and education contract. And finally, we're able to award that in August, which is very exciting. University of Washington was the recipient of that, and they're actually partnering with 3 other universities. And tucked within that team across all those universities are 6 American Indian or Alaska Native researchers or practitioners. And so what's also kind of cool about that award is they are building off of their work as an ADRC. And so it's nice to be able to, I think, bring those things together. The other 2 pieces that we have going on, I think that we've talked about before, are our Geriatric Nurse Fellowship and the Indian Health Geri Scholars, all of which really relied on the foundation of the work done by the VA and their Geri Scholars program. I think we're finding great success. This year, our Geri Scholars cohort, which is principally providers and pharmacists, we had the largest number of applicants this year, and I think a good portion of those were pharmacists. So not quite sure how we hit the mark on those guys, but it was nice to see a different group of folks step in. And then the other group is Geriatric Nurse Fellowship. We're actually openly recruiting, and I think we have trepidation and excitement that our social media messages have been shared, I think probably a few hundred times through the IHS network. Last year, I think we got 20. And so I think, we're nervous but excited because we only have 20 spots available for that. So we should be closing that out in a month. Next slide. We've also been working on over the last year, the mini cog, really kind of training, supporting initiatives in the community in that space. And we had a blog that came out where we tucked up some messaging about mini cog, early detection, early screening. We had a pilot project that we did earlier this year with our CHR national lead, had some great results, I think interesting results. What we found is CHRs can screen. I think there's some barriers in the process in terms of receiving referrals kind of in the clinical setting and then closing the loop in that space. But we were excited. It was quick and easy, 6 months. And we are currently recruiting for another round, hopefully 10. We're hoping to get 10 sites in this one, but announcements just went out. And so we should be recruiting and starting another round of that in January. Another great partnership opportunity, Oklahoma University Health Sciences Center is providing some basic dementia education for our CHRs. And what we heard in our first pilot was we gave them a little, it wasn't enough, and they needed to do it in person because they have a lot of questions. I think the other thing that we found in that space is that there's a lot of trepidation about implementing a screening tool. I think we found it with our dentists as well. And so they really need to build confidence even in that space with a tool that's relatively simple. The other piece that we worked on over the last year are some mini cog videos that feature some of the staff from Indian Health Council. You see Dr. Dan Kalick, he's also one of our grantees. And so we have 2 demo videos. Really the purpose of those, because there's videos that already exist, but was to center American Indian and Alaska Native people. So the faces and spaces and places. So we have 2 out and we have 2 more coming that sort of provide context and build on that one. Next. I think we talked about this, maybe CDC, I think, talked about it. And I think Bruce touched on it a little bit as well, but we're able to get out an article with some research results. And I know that went out to the NAPA listserv as well. So we're excited. I think that was also a long time coming with partners at Alzheimer's Association and CDC. The big finding, I think the takeaway that probably got the most attention was the relatively high percentage of younger people, 55 to 64, who were in the cohort who were diagnosed with dementia. So I think we've reiterated multiple times in our talking point, this wasn't meant to be like a prevalence study of any way, shape, or form, but really sets the mark for us in a way that we've not ever had our own data to look at. So excited about that. Next slide. I think this is the last one. The other thing that we did is we've established an Indian Health System caregiving work group. So we have ITU folks, we had pharmacists who joined in, They're meeting every other week for 6 months, which is a really intensive ask for a bunch of clinical folks, but they're hanging in there with us. We also are excited that we have some representation from ACL's ADPI grantee, so Aaron's grant program. There were 3 or 4 tribes that were funded several years ago, and they've really actively joined into our group. So it's really great to see both clinical and community folks represented. And we are really just walking through the interventions that we think have the potential for the greatest success to give us some ideas about where we might go next. And then we think when we're done, probably around December or January, the idea is for these group of folks to provide some guidance and recommendations to us on innovation spaces, caregiving, coaching, kind of what we can do. So I think that's it. Yeah, website updating actively. So please take a look. Thank you.
Thank you. And over to NIH, starting with NIA.
Thank you. Thanks for the chance to summarize some of the things that have happened since our last meeting. Next slide, please. And next. Just last month was the 2024 Alzheimer's Research Summit. I hope many of you were able to join. There were over 1,100 people combined in person and online. As you'll know, this is an annual event, each of 3 different summits: the Alzheimer's Research Summit, the Alzheimer's Related Summit, and Care and Caregiving Summit. So each year, one of these is in rotation. There were multiple themes, as you can see here, but the focus was around precision medicine, as we are increasingly able to understand the complexities of the disease aids in individuals, design diagnostics and ultimately therapeutics to approach each of them. Major themes include this complexity, resilience in the face of otherwise risk factors for dementia and those who manage to avoid disease, understanding the neuropsychiatric symptoms in disease as well. Next slide. As one of the monitors, we share with you periodically the active NIA supported AD-ADRD clinical trials here by category, pharmacologic and non-pharmacologic first. Of note is the diversity and the increasing diversity in the targets for each. But if we look at the phase 1, 2, earlier phase trials of 54, only about 6 are targeted at amyloid, which, as is perhaps the longest standing target. But this reflects our increasing understanding of the multiple pathways involved, ability to design targets, and ultimately to use individual and probably combined therapies to address the multiple causes of disease. For the 13 phase 2, 3, and 4 advanced trials, although amyloid is the most frequent of targets, it's a minority among them. And we again see the diversity coming from basic science through the early phase trials into these definitive trials. Similarly, for non-pharmacologic therapies, there are multiple of them, and we see the time when combinations of pharm, non-pharm will probably be most effective in addressing individuals at risk for or with dementia. Next, please. For AD-ADRD clinical trials focused on care and caregiving, once again, a large number of them, over 200, using multiple strategies in multiple settings for the institutionalized, for in-home, for independent livings. The first of these are making their way into dissemination with further evaluation to see what works. Important among the other categories here, underlying disease processes, trials, diagnostics, the biomarkers, which are playing an increasing role as new biomarkers rely not entirely, for example, on imaging, but on blood and fluid biomarkers. Important because they allow accessibility to diverse populations and a more effective way to screen into clinical trials or screen for clinical purposes. Next, please. Just a word about the A4 clinical trial. It was a study that was one of the first targeting early stages of Alzheimer's disease. It was not positive in the sense that the intervention did not slow the onset of disease or its course, but it was really a landmark in that it set the base for sharing of trials. So trial data here made widely available to the research community, hundreds to thousands of hits, and we trust that this will be the landmark, the standard by which other trials will be conducted. Importantly, for the more people who have access to studies, the more they can see these results, use them in designing the next phases of research. Next, please. To remind folks of the process by which we arrive at ultimate funding of research, it comes through many inputs. The summits that we talked about, the annual Alzheimer's Association-sponsored Congress, multiple workshops, all these to inform investigators. Investigators then, with their input, examined by staff across all of NIH, with a transparent process of looking for it might be the highest priority initiatives to fill gaps. These in turn are presented to our National Advisory Council on Aging, or NACA, at each of its meetings 3 times a year. And the approval of concept by council is an essential necessary part of the transparency and the go-ahead to take these into set-asides funds for clinical trials. This is a listing of some of the diverse that were approved just last month at September Council. You can see they range from digital technologies through National Centralized Repository for data, the basic science, caregiving, all of these through, again, with emphasis at the end of a long process with multiple inputs, we use to ensure the transparency and the widest possible input and recruitment of wisdom and perspectives into our ultimate research enterprise. Next, please. In addition to these usual grant mechanisms, we have for the last years used challenge as another way. The Eureka Challenge in particular is targeted at ways in which we can find early prediction of disease through digital inputs. This is not a grant award. This is a challenge that is people submit their accomplishments, and those who are successful receive the awards or prizes. First phase is to identify the databases that will be useful. The second is to show their feasibility, and the third is to put it all together. Next, please. And let me turn to my NINDS colleague for the NINDS perspective on NIH research.
Okay, I'm the program director for frontotemporal dementia research at the National Institute of Neurological Disorders and Stroke. I'm also part of the scientific leadership team for our AD-RD program. We're enthusiastic about continuing to partner with the National Institute on Aging to address the first goal of the national plan to prevent and effectively treat AD-RD. Next slide, please. I'd like to give an update on our VCID program. That's vascular contributions to cognitive impairment and dementia. Cerebrovascular problems are strongly linked to AD and its related dementias. And these problems are quite diverse. You can have microbleeds, infarction, cerebral amyloid angiopathy, arteriosclerosis. And so it's complex science space. And we created last year a funding opportunity called a Center Without Walls for VCID. We encouraged diverse science, diverse perspectives on this hard problem with the expectation that awards would come in under the CWOW framework, where we'd have a sharing of ideas, sharing of data, hopefully collaboration. And we're happy to announce that we have 6 awards that are geographically distributed, you can see in this map here. And they cover different perspectives on VCID science. You can see that the bullet points there show the topic of the different awards. So we have cerebral amyloid angiopathy covered, arteriosclerosis, atherosclerosis, inflammation. And so we're excited that we think this comprehensive framework, this comprehensive approach is going to help lead to better prevention and better interventions in the future. And I'll also add this, the leadership team is going to be Gareth Howell at Jackson Lab in Maine. Okay, next slide. I'd like to announce just our AD-RD summit that's going to be hosted by the NINDS. Dr. Hodis mentioned their AD summit, which was fantastic earlier this month. And hopefully ours will be fantastic as well. It's going to be led by Dr. Kate Posin from UCSF. Save the date, March 25th through 26th. This is, every 3 years we have this summit, and it's going to inform our scientific priorities. And eventually from this summit, we're going to create new milestones that will go into the national plan. Okay, and that of course is part of a FACA process, and we really encourage public participation, and we hope you all will participate too. Okay, next slide, please. And I'll leave with just an interesting scientific update from Dr. Ji Shen at Harvard Medical School. This project that was published in PNAS is part of our AD-ADRD portfolio at the NIH. So she put a p-senilin mutation in a mouse model, and this mutation causes an aggressive autosomal dominant familial Alzheimer's disease. And in the mouse model, they see cortical degeneration. And then they also added a knockout of amyloid precursor protein. So this model, in addition to having the presenilin mutation, no longer produces amyloid beta. And what they found was that they had the same cortical degeneration with or without amyloid beta. So in this mouse model of genetic Alzheimer's disease, amyloid beta had no effect on the cortical degeneration. So it does suggest that passive immunotherapy might not be effective in some genetic forms of Alzheimer's disease. However, this is just one mouse model, and I'll say most, as you know, Alzheimer's disease is sporadic and does feature amyloid beta pathology, but nonetheless, it reminds us that we need to continue to look at alternative mechanisms, alternative approaches to dealing with AD, ADRD, just as Dr. Hodes had mentioned before. I'll leave it at that. Thank you.
Thank you, everyone. Questions? I know we have one.
Thank you, Ellen. Dr. Hodes, I'm glad you addressed trust to start off the meeting, but also spoke to a little bit about process within your presentation. As a member of the scientific and advocacy community, we know how extensive the work is to establish direction and the scientific discourse that goes into that. Can you speak to your confidence about where we are right now and the funding and where it's going?
Thanks, Joanne. Well, I think commitment and confidence without complacency is probably the summary, I think, of where we are. So I have great faith in the directions we take because those directions are based on input from the research community, from advocate communities, from people living with dementia and those who are partners with them, all of whom share their insights, identification of priorities, research gaps and opportunities at a wide variety of meetings. Those are all public these days, especially with our ability to allow virtual or hybrid meetings. It means we have a larger audience than ever. And the inputs are, as I've noted, the critical words are transparent and meaningful. They lead to NIH-wide then distillation of those identification of priorities, and those priorities then receive still further scrutiny by the National Advisory Council on Aging, input from this committee as well. I think to the degree in which we fulfill our past commitment and our continued resolution to maximizing input and transparency, making sure that no particular research perspective or individual or group has disproportionate impact to the extent that it narrows our scope and limits our ability to identify new and emerging areas of science. I think we continue to have this high level of confidence and invite scrutiny and challenge to that continuously. It's not an area in which we can deserve or want to be complacent. It's rather an ongoing commitment. And we welcome recommendations from all of you, not just the scientific input, but the process itself, a way in which we can continue to involve all of you who have a role and a commitment, along with us at NIH and other research funders, to partner in continuing research. I hope that addresses the question. I'm happy to answer any other aspects of it that any of you might have. Nothing more critical, I think, these days than faith and trust and confidence in what we all are doing together.
Okay, thank you very much. We're going to shift now into a break. It's going to be only a 5-minute break. I hope everybody comes back promptly, and those who are in the room will be able to order lunch in advance. So thank you.
Produced by the U.S. Department of Health and Human Services.